Good afternoon, everyone. Thank you for having me and giving me the chance to present today. So let's talk about depression. What the hell depression? Depression. I'll just go through the depression definition, diagnostic criteria, and we will speak about the manager and some near infinite management for having of depression. So yes, define depression as tied with the men's psychiatric illness. It's basically as a constellation of effective commitment and somatic symptoms persisting for at least 2 weeks, leading to an impairment in functionality of the client or the patient. It's among the leading causes of disability worldwide, from associated with increased morbidity and mortality, especially clots. Now, according to the DSM-5, there is the diagnostic criteria which are listed. So from the list below, we have at least to have 5 or more of the symptoms, and for a continuous 2 weeks period of time, and then there is a change of functionality of the patient. At least one of these symptoms must be at breast load, and the second symptom must be at least loss of interest or anxiety. So main complaints would be because fluid most of the day, every day, diminished interest for pleasant activities, weight loss or weight gain, anxiety or hypersomnia, and psychomotor agitation, elder vibration, fatigue, loss of energy, recurrent suicidal thoughts, or fear. So the management of depression. So it's a whole set of management parts, so it's like psychotherapy, medication, like changes, and that regulation, pre-stimulation, perfectionist, and banana becoming an operator. And here I have to cover why reliance from a daily network promote anxiety treatment. We had quantitative updated to guideline for the treatments. So the phase of the treatment goes from acute to maintenance. The acute usually for 8 to 16 weeks, or until symptoms are remission, where we address the patient safety. So we assess for suicidality, we define the treatment to be inpatient versus outpatient, and develop the safety plan. And then we go for treatment of symptoms remission, alcohol, and incontinence. Here we need to establish the rapport with the alliance, psychoeducation and self-management, and then monitor the stability and accurate response and side effect of the treatment of choice. The maintenance usually goes from 6 to 21 months following an acute phase, or longer if clinically needed. Here we need to maintain the symptomatic remission, restore the functioning frontier fly to the pre-morbid levels, prevent recurrence, and consider gain relative treatment or distinguishes. Can criteria level above that as it is, go from level 1 to level 4, from the highest to the lowest, what they see expert opinion. So here just going to have some summary of the recommendations in selecting initial treatment. Based on the civic. So usually from environment and low safety risks, there is no difference between starting psychotherapy or pharmacotherapy. They demonstrate the similar effect. Moderate or low voltages, here we choose between psychotherapy and pharmacotherapy, which one would help where easily the depression would deal with suicidal thoughts, and structured psychotherapy and CBT in specific is like in water fishes in the medium term, the 6 to 12 months. And then we would go for severe and moderate illness. Here without psychotic symptoms or with psychotic symptoms, and then depending on that, we would add on an antidepressant or accompanied with antipsychotic. Here just a long list of meditation. So usually as a first one in depression, we would go starting with an SSRI and SNRIs. And then for the second line, we to the TSA, and our third line usually are the mal inhibitors. Now, some side effects and safety measures in the medications, hyperinsulinemia as well as the insulins are strongly associated with SLDF, and especially for older adults. So, manapine, we usually prefer bupropion, which have lower risk of hypertension and mercazine. Monitoring, so we do the podium at baseline, and then 1 to 3 weeks post starting implementation, and eventually at significant indicator. Regarding product safety, citalopram and citalopram carry a dose dependent on QTC prolongation. This allows mild increased blood portion, KSA, and then aromatogenic potentials. So usually as a safe option, we go for a sertraline, which is an SSRI, especially for patients with ischemic heart disease and arrhythmia. Alternatively, we can choose a saltitotar with an STG monitoring. So one of the new medications that we're given, recently we started as well, clinic and SAFA. So esketamine is an engineer of ketamine. It develops as rapid-acting antidepressant, and it targets acknowledgement neurotransmission. Now, in 2019, it was FDA approved. There's the providing for treating resistant dystonia and POTCD. Now, a mechanism of function, esketamine is a non-competitive NMDA receptor antagonist. It's the inhibition of NMDA receptor enhances NMDA receptor robust because of glutamate signal. This cascade activates brain to drive neuropathic spectrum and mutual factors, somatic psychoanalysis, and neuroplasticity. Esketamine produces antidepressant effect within hours to days, certain 1 weeks. Now, the administration is the nasal spray under metacarcinal version in induction phase twice daily for 4 weeks, and then we go for a maintenance phase, which is weekly, or over every 2 weeks, depending on the thoughts. But according to the guidelines, it's mostly combined with an oral vasopressin. Now, due to the burst of dissociation and transient hypertension, patient must be monitored for 2 hours post the dose interval. The question will be shown here that why it is combined with an antidepressant, because the initial study was done on esketamine as a therapy or a corporate treatment with the important antidepressant. Now, the evidence on the redundant efficacy in the randomized control clients are promising and shows significant reduction in the persistent symptoms, ASALs and compression, and durability and remission rate are higher than placebo or combined with what I was expected. Now, the safety and their side effects usually are talking about the side effects I mentioned before, and that's why we need to do it as an in-house. Just to start with the doses, this is just a scan of the doses and the induction phase and the maintenance phase. Neuromodulation, I'll speak here about ACT. So ACT is a already established treatment in depression. It's clinically indicated for severe cases of depression that combined with psychosis, suicidality, or severe function impaired catatonia. And it is used with pregnancy associated with depression. Mechanism of action, it's generalized clonic seizure throughout the detection of electrical stimulation to the sound. This electrical therapy is through the neuropathic changes of modulation in the transmitter system. So serotonin, dopamine, GABA, and glutamate. And it causes aggregation in the both. The response rate shows 70 to 90%. The remission rate are approximately 50-70, even in the treatment of the population. It's a global panel in catatonic depression. The safety and side effects or first effects, the common one are the nausea and malaria headache. There is always a concern regarding the memory loss. It's a breakout antiretrovirate anti-TB. But in the namely Saturday recently, after the treatment surgery, these kind of sound effects improve. The limitation is usually assumed to be stigmata of ACT in the public. Pre-ACT assessment usually it's a history and physical exam, investigations and baseline and ECT. Now there's absolute contraindication for ACT, including unstated releases microbial infarction with this 4 to 6 feet, uncontrolled arteries, intracranial mass lesion with elevating and recurrent pressure, facing stroke and uncontrollable potential. The related modifying conditions including optimizing NSA heart disease, controlled blood pressure, COPD and asthma with an adequate oxygen medication. Like we needed measures of really good health. Pregnancy is safe, but we need obstetric operation. Now, hypertension must be corrected prior to SNT because it increase the CGPS. Currently monitoring ECT is stable pacemaker. Some medications need to be adjusted, including mood stabilizers like lithium and benzodiazepines use. And lastly, I will speak about TMS, postprandial magnetic stimulation. Recently, we started putting in 4 TMS in our hospitals, and it is a growing factor in the management of depression. Now, it is a non-invasive neuromodulation technique. It allows focused magnetic field to simulate specific cortical regions. It works by delivering a rapidly changing magnetic pulse through a coil positioned over the skull. These pulses induce electrical current in the non-cortical neurons, modulating neuronal excitability and synaptic processes. Now, repetitive TMS can produce elastic during cortical activity with high frequency stimulation, generally producing excitability. The FDA approved it for obsessive compulsive disorder and major depression. Now, the meta-analysis identifies control problems. We found that TMS is superior treatment for NDFA, where the response rate is about 30 to 50%, and initial rate of 20 to 30% in treatment-resistant population. TMS is generally well tolerated with favorable safety profile. Common side effects include the scalp discomfort, transient headache, and mild pressure friction due to the nerve stimulation. Now, the TMS compared to ACT does not have cognitive impairment, in contrast to ECT. Contraindication include metallic implants to the snow, cochlear implants, and active tips, which is the NHS. Now, the limitation usually identified as it's because the treatment efficacy and limited availability of trained clinicians and equipment, and the need for frequent visits. Just slide to compare the efficacy, where we find that the best is the ECT in regards to efficacy. Risk TMS is the best one, in the state FC is second. Thank you so much.